It's okay.
Thank you very much for coming. This is the Red Rock Island. This is a tremendous audience, and I appreciate everybody coming to try to bring everything out this time. First, if you don't mind, I would like to salute the flag. I pledge allegiance
To the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
The agenda's up on the wall. I appreciate if everybody that has a cell phone, be sure that it's not going to ring. You all came here tonight because you have concerns about our doctors remaining here in Lake County. There has been considerable misinformation, spreading around the community. Our purpose tonight is to provide facts and assure the community that the entire healthcare system is working to resolve issues. The board has hired Gordon Inslee on a short-term basis to work directly with the Lake County Medical Clinic doctors to seek a better solution to their concerns. Many of these concerns relate to overwork, hospital expansion, and desire for a better family life for the doctors. Gordon's charge is to help design a better doctor-hospital relationship that will serve all our patients and allow less stress for the doctors. Gordon tells me that Dr. Gallagher and Dr. Hussey are working in very positive direction with him. This has been going on for several weeks and has a ways to go yet. Bottom line, we need more local doctors, a revised ER and OB structure, and other doctor perks. Our doctors feel underappreciated, although all of us, and I'm sure all of you, appreciate them very, very much. Running a hospital is far more complex than just a clinic. I want you to appreciate the hospital district structure and some of the issues of change that we are going through. Then we will get to further questions you may have. There's a number of slides I prepared, and I'm not a very good slide preparer, so bear with me a little bit. But you'll be pleased with what you hear up here, I think. I want to look at the mission statement next. This is the mission statement for the Lake Health District. The mission statement of the Lake Health District is to provide appropriate healthcare services. Those services will be provided at the highest level of medical and ethical standards possible through the effective utilization of resources. This is the Health District Board's goal. All right, the next item is to the Lake County community, and I would like Lisa to read this if she would please. She's the one who prepared this. Did a beautiful job. I'm not reading my own agenda. I apologize. I forgot the introductions here. Starting right here is Charlie Twait, of course, Don Liedtke, Judy Graham, Carol Stewart, and Bob Swart. We're the 5 board members. Farther down is Dr. Chuck Hoffman and Kevin Campbell, and they're both here from the EOCC, which you'll hear more about here in a little bit. Of course, we have our secretary, Jen, down here, and Jim Lynch, our attorney, and Lori Crocker, who's going to run the show tonight when we get to the questions. And Lori, you brought some helpers. I don't know where they're at here.
I did, and as the evening evolves, you'll find out how they're going to handle the question, how the board would like to handle the questions. And the three helpers that I brought that you can turn questions into will be Judy Stewart. Judy, are you in here? And Susan Codd and Debbie Simentaki. And these ladies will be out in the lobby, and you'll get to know them a little bit later.
Thank you. Now back to the medical staff statement prepared by Lori.
First, I'd like to say that this letter was prepared not only by myself, but by other members of the medical staff, okay, that I'll mention at the end. And I do have copies of this if you would like a copy and you cannot hear me. To the Lake County community. As members of the Lakeview medical staff, we would like to address some of the issues that have surfaced over the last few months. It has become apparent over the last few years that practicing medicine the way we have practiced in the past is no longer sustainable due to many changes beyond our individual control, including both federal and state law. Because of this, changes are necessary. While we are members of the medical staff, we are individuals also, and the changes in the environment have impacted us in different ways. Finding a common path is always difficult. However, we as the medical staff feel confident that by working together, we can find ways to explore and work out solutions that better meet our needs as individuals and as medical staff members. Our common goal as a medical staff and individual members is to help adapt to this change and ensure quality medical care for the people in our community and adjacent communities. Some of these changes are already underway, and I will highlight a few of them. Number one, Dr. Clark has chosen to take a sabbatical, and we wish him well in his endeavors. Number two, Lake Health District is in the process of working on new ways to support existing medical staff members and bring in additional help to care for our patients and to meet our mutual obligations. Number three, we welcome into our community Dr. Lance Lee, MD, and his family, and we are excited to work with him. We also encourage the Lakeview Health District Board of Directors to continue to seek other practitioners who would like to relocate to our rural community. During this transition period, there is always speculation and at times turmoil. We would like our community to realize that we are, and always have been, committed to providing excellent health care to our citizens, and we are confident that although change is going to happen, that we can all come to a resolution and continue to provide excellent health care to our citizens. Sincerely, Dr. Tim Gallagher, Dr. Stephen Hussey, Dr. Scott Graham, and myself, Lisa Cahill.
Thank you very much. The next slide that we have up there is, that's the way I feel in the morning. How's that? That'll work better. Dr. Clark mailed a statement out to his patients, and this is what he said on the thing, and I'm going to find the slide now. Dr. Clark wrote this: "Dear friends and patients, I have found it necessary to take a sabbatical from my practice at the Lake County Medical Clinic, effective May 12, 2015. This has been a very difficult decision for me, but has been long in the making. Due to recent events, our ability to absorb all of your needs here at Lake County Medical Clinic is limited. I truly apologize for any hardships this may cause, but I hope to return and continue to serve you all in the future. Regards, Spencer Clark." And we thank him for what he's done, and we do hope he returns soon. Now, Dr. Gallagher and Dr. Hussey also presented us this afternoon with the next slide, which is a letter, and I'll read it to you. It says, "To all interested parties, the recent efforts to make changes now underway has created uncertainty and speculation, and we want to share our immediate plans. The Lake County Medical Clinic and its physician partners have been operating in a difficult environment, and working with the Lake Health District's Board of Directors, we came to the conclusion it was necessary to make some changes. A decision was made by Lake County Medical Clinic partners and Lake Health District's board to move forward to sell the Lake County Medical Clinic business to the district and prepare work agreements for Lake County Medical Clinic's partners to continue their practice in Lakeview. This change, along with bringing in additional physician, supposed to be S, I think, to help share the increasing workload, will help resolve many important issues for both Lake County Medical Clinic's partners and the district. While the sale and the work agreements have not yet been completed, we are optimistic and expect to remain with our practice in Lakeview." That's very important. I'm going to talk just a little bit about the district. First off, the role of the Board of Directors. Our job is to operate as a group of 5 directors to govern the health district. We select and employ a CEO administrator. We establish goals for the CEO, both immediate and strategic planning. And we appoint a medical staff of providers. Now, the role of the CEO. I don't know if you're following me, Cheryl, are you? Yes, thank you. The CEO, administrator, he is the direct executive representative of the board in the management of the district. He's responsible for the administration of the district, responsible for all staff of the district, act on behalf of the board to enforce all policies adopted by the board, operate the district in a legal and fiscally responsible manner. There's the role of the medical staff. They operate under the medical staff bylaws to provide patient care independently throughout the hospital. The bylaws are a 27-page, my spelling's not very good, document that covers all phases of doctor responsibilities and complaint resolution processes. They cooperate with each other and the administration to provide the best care possible. Hold regular medical staff meetings monthly to discuss improvement of care and treatment of patients. They elect a chief of staff and a vice chief of staff annually. And that person comes to our board meetings. And they recommend appointments to the medical staff for hospital privileges. They do the recommendation. Actually, the hospital does the background. The doctors do the recommendation, and the board does the approval of new doctors and re-establishing old doctors. They resolve medical issues informally when possible, and if it's not, then there's a procedure that they go through. They meet quarterly with the district board of directors, and I would just note that this is an area that we all need to work on improving our communication, because we could have avoided a lot of this if we'd have talked to each other better. Now, the medical staff who provide ER services. These doctors sign a physician agreement to provide ER service. That means emergency room on a rotating basis. Currently, these consist of Dr. Gallagher, Dr. Hussey, Dr. Clark, Dr. Graham, and family nurse practitioner Lisa, and I misspelled her name, Lisa, I'm sorry, Lisa Cahill, with special oversight from the other doctors. I want to point out that we only have 5 local providers to fulfill the rotation schedule. This is the same number we had for at least the last 7 or 8 years. Yet the ER activity has steadily increased over these years, along with the OB activity. This is a big reason why our doctors are overworked. Weekday shifts are regularly scheduled 24-hour periods, 6 a.m. to 6 a.m. the following day, except Friday, which ends on 6 p.m. Friday. Weekends are scheduled from Friday at 6 p.m. until Monday at 6 a.m., and holidays have some special rules. The physician must be available in-house to patients needing emergent care within 15 minutes. They can be at home, but they got to be able to get here in 15 minutes. If it's only an urgent care level, then they've got 30 minutes to get here. That's how the ER is run at this time. Now, one thing that several people have asked about, and I wanted to just reiterate it, ER doctors are paid for 24 hours, and they're responsible to come to the ER and see a patient if the following things happen. The patient is an emergency trauma patient. The charge nurse deems it necessary. The patient insists on a physician examination. The patient is an ambulance patient other than a transfer, and all the codes within the hospital. So if you're in the ER, or you brought your family into the ER, and you feel that the doctor needs to come in, and the doctor's trying to talk you out of it, you've got the right to say, yes, you come in. Now, for some recent history of our district, so I started back in 2007, Bob Swart and I. We're the old timers on here, actually. Replacement of our almost 40-year-old hospital with a modern new facility. These are all the things that have transpired. Addition of many new services with additional specialty doctors and new equipment. We currently have 15 doctors that work here, along with considerable telemedicine to read our x-rays, MRIs, CAT scans, echocardiograms, sleep labs, studies, and so forth. We provide cancer treatment, procedures, spine injections, carpal tunnel surgery, general surgery, OB, and many other procedures. This has been made available by lots of training and investing in the latest technology. Our new wide-bore MRI is as good as any in the U.S. And of course, we've got relatively new X-ray equipment since the new hospital got here. CAT scan is new. The digital mammography is new. We're out in the leading edge of good medicine. Our total budgeted revenue has increased over 60% since 2007. Also, the number of patients served in Lakeview instead of having to leave town have steadily increased. We now receive over 10% of our business from California residents. In 2003, Charlie found a study that showed that it was just a little over 2%. We moved up to 10% of our business out of California. Why did they come? Well, we got a new hospital. Their hospital doesn't do OB. Their hospital doesn't have an MRI. I mean, it just goes on and on. And we've also developed a clinic down there to give those better recognition in the community. We benefit very much from this increase in business because it helps us expand our specialty services. We can bring in more doctors. It pays for equipment that we bought and lots of training investments that we've made. We've encouraged their use of our facilities and services instead of their patients having to travel to Reading or Reno for service. This is a win-win for both of us. We will continue to grow from the Affordable Care Act rules because more residents have insurance coverage. 26% of Lake County residents are eligible for Medicaid services. Although so far we haven't served that many, but we expect to. In addition to these services, we have converted the long-term care into Lakeview Gardens for better Medicaid reimbursement, and we're in preparation to build replacement cottage facilities for long-term care and an assisted living cottage. So you see there's a lot going on. Changes in healthcare affecting doctors in the hospital. I believe Dr. Hoffman down there will tell us a little bit about the EOCC, which is really a big thing. If you'd like to come up here.
Sure. See if I can weave my way. I'm having a little bit of a flashback here. I rarely need a microphone. Can anyone not hear me without the microphone?
It helped.
Oh, there's people in another room. Okay. All right. Well, the reason I'm saying I have a flashback is I spent 14 years on the Baker City Council, including 3 terms as mayor. And when I walked into this room, I said, "Oh my God, what have I done this time?" But I really do appreciate the opportunity to be here tonight and to tell you about the Eastern Oregon Coordinated Care Organization. I know it sounds complicated, and I feel a little bit like, you know, I'm here to tell you something, but I think the important thing I want to start off with is to let you know Kevin and I are just like you. I grew up in LeGrand. I married my high school sweetheart. I went to college in Eugene. I went to medical school in Portland. I went down to Arizona. I came back, moved to Baker, started to practice by myself in 1981, and I've practiced internal medicine since that time. So I'm really just like you. Kevin grew up in Monument, if I'm not mistaken. Kimberly, there you go. So somehow I found myself appointed by Governor Kulongoski to an organization called the Oregon Health Fund Board. And that was in 2007. In 2009, the Oregon Health Fund Board got turned into the Oregon Health Policy Board, and I served on the Oregon Health Policy Board until 2012, when the legislation that created CCOs was established by the legislature. Now, the Health Policy Board was charged by the governor with taking a look at the unsustainable costs of the Oregon Health Plan. We were facing a $289 million deficit. In addition, we were looking at the potential expansion of Medicaid services to adults that came about because of the Affordable Care Act. We took a look at the Oregon Health Plan system, and we found it to be very fragmented. We found it to be fragmented into medical services over here, and psychiatric services over here, and dental services over here, and then there were people who weren't enrolled in any of that. And I'll be honest with you, it was an absolute mess. It was expensive, and it was not producing the quality of health care that was necessary. So we said, wouldn't it be wonderful if we could integrate the health care provided to these patients and give it the flexibility to redesign the delivery system and the payment system and give local communities the control to do that, and create organizations that were locally controlled. That's what we did. That's what Senate Bill 1580 did. Now, we weren't exactly sure how this was going to work in Eastern Oregon. You know, my vision at the time was there would be several organizations, several CCOs throughout the eastern part of the state. Well, if you take a map of the state of Oregon and draw a line smack dab down the center of it, everything to the right of that line is Eastern Oregon Coordinated Care Organization. The 12 counties of Eastern Oregon make up this organization. They are your neighbors. They are on the board of directors. Charlie serves on the board of directors. We have physicians from Eastern Oregon on the board of directors. We have a clinical advisory panel composed strictly of providers from Eastern Oregon. Now, I think so I told you this all started back in 2012, right? That's when the legislation was passed. So CCOs are not new. I mean, it's been, you know, well, it's been 3 years now. Providers from every county have bought into the concept of local control, provider-driven care, lower cost, and improved quality. Okay? There's one county that's not true in. Every county we have every county of the 12, we have a majority of primary care providers enrolled in the CCO. We don't have that here. We want to have it here. We want to work with the providers. We've tried, I'll be honest with you, you know, from my standpoint, we've bent over backwards more in this county than any other county to try to help the providers.
You want to tell them what to do?
Hold on just a second. So we've tried everything that we could to, you know, again, we have some rules and regulations. So the point about these CCOs is they are locally driven. Now, I understand nobody in Lake County wants the government to tell them what to do. Nobody in Eastern Oregon wants the government to tell them what to do. What I'm trying to explain, though, is these organizations are locally controlled. You have your own county local community advisory committee. Do any of you sit on that? Do any of you know that this organization exists to advise the board of directors on local county issues? Good. So again, you know, I hear the question. No, we're not trying to tell anybody what to do. What we're trying to do is help you tell us how to provide the best care to the people enrolled in your community in the Oregon Health Plan. I know, again, I'm from Eastern Oregon too. I know all about, I'm from the government, I'm here to help you. Okay, I get that. But I'm not from the government. I'm just like you. Kevin's just like you. You know, we're all trying to make this work. And we will do whatever it takes to make it work in this county. I promise you that. My number's in the book.
Oh, we heard.
All right. Thank you.
Thank you, Dr. Hoffman. Kevin, did you care to say anything?
Oh, sure.
Kevin is the CEO of Gobi, who is a 25% owner of the EOCCO. Now, I'll let him figure out how to explain that.
I'm afraid this thing will bite me. But let me clarify a couple things that Chuck said that aren't quite true. We're not just alike. I did not marry his high school sweetheart. And Ken Kestner actually sits on the EOCCO board rather than Charlie. Charlie comes to most of the meetings, and I know why Charlie comes to most of the meetings. Like Willie Sutton said, the reason they rob banks is that's where the money is. And that's where the money is with the Medicaid funded benefit in Oregon is with the CCOs. I've been the Chief Executive Officer of GOBI, Great Oregon Behavioral Health, since 2001. And when Governor Kitzhaber was elected, and he said, I have enough trouble dealing with one insurance company. I don't know how Oregon's most vulnerable citizens can deal with three. A medical insurance company, a mental health insurance company, and a dental insurance company. And that's the world we came from. Every person on the Oregon Health Plan had 3 insurance companies to deal with. Most of them had different rules. Well, when the governor said that, we knew that those days were numbered and over. And Dr. Hoffman and his group had recognized that before. We have to have coordinated care. We got together with MODA, which was a physical health plan, and we got together with Advantage Dental, which was a dental health plan, and we started talking about what an Eastern Oregon coordinated care organization could look like. I grew up in Grant County. My family owns a ranch. My dad is there. My sons are there. And I hope that my grandchildren can make a living and their children can make a living where I grew up, because that's pretty special quality. I was crazy enough to run for county judge. I was elected. I served for 6 years, and so I'm kind of like Chuck. I have a little trauma coming into groups like this. You know, I know about long ropes and nervous horses. But the reality is, what makes a CCO work is relationships. And it's not coming out here to snooker people. It's listening to you and understanding your challenges. I know how hard it was to recruit doctors in Grant County. I know what it's like to pay taxes in a community with a brand new hospital and a very uncertain health future. Look around us. Look at what the rest of the world is doing to deal with containing the costs of medicine. Big hospitals are buying bigger hospitals. Systems are getting bigger and bigger. And my greatest fear in Eastern Oregon is that our 10 local hospitals would be closed down and replaced with an emergency, kind of a MASH unit and a helipad to move people to bigger hospitals to get their care. Our goal is to see that the maximum amount of the over $300 million per year that the Eastern Oregon CCO gets is spent within the boundaries of our 12 counties. And that's not just on medical care. That's on preventative care. That's taking care of our kids. We have a community health improvement plan that talks about 5 basic issues. Number 1, better integration of care to our kids under the age of 5. Number 2, breaking down the barriers and the stigma of accessing behavioral health services. Number 3, better use of community health workers and system navigators, which means more jobs in the community, care extenders to the medical professionals. Number 4, better integration with public health and bringing public health and preventative care more closely aligned with our goals of medical care. And the 5th is a dental initiative that says that every child has the tooth decay eradicated from their mouth before the age of 10. If we can accomplish those things, we'll be leaders in this country. And we should settle for no less. And I want to see communities own their healthcare system, because that's 17% of the gross domestic product. And if we think that we're going to change the world from the top down, it'll never happen. But if we can change it from the bottom up, I'm willing to bet my career and my life and whatever else on it. And I'm sorry there's a lot of anger. I'm sorry there's a lot of confusion. I'll shut up and I will listen. If there are pointed questions, I'll do my best to see that Chuck answers them. And I just want to tell you, I appreciate being here and I appreciate the anxiety. None of us want to lose our doctors. All of us are going through a lot of change. And I truly admire both the healthcare professionals in this community and the people that serve on your health district board. Thank you.
Thank you. I want to point out something that you saw on Dr. Gallagher and Dr. Hussey's slide there, we're negotiating with those doctors in that clinic. And Dr. Clark's on sabbatical, so at the moment he's not involved, but he's welcome to be involved as quick as he can. To come into the hospital-owned rural health clinic. What does that do? That provides that we don't get the situation that Dr. Clark talked about some months ago of having a clinic for Medicaid patients and a clinic for all others. We're all under the same roof that way. The hospital is contracted with the EOCCO, so there's not a problem there. There's other factors that are very beneficial because of the way the Affordable Care Act is set up. The hospital gets better payment for a visit than the private doctors do. I don't say that it's fair, but that's the way they've set it up. So there's lots of things that will be better when we get through with what we're trying to accomplish. I wanted Charlie to say a few words about the rural health clinic.
Just want to say a couple things about why would we want to have a rural health clinic, and why would that, you know, a lot of people have said, oh, you're competing with the doctors. Well, a couple things to keep in mind. As you've heard before, this month is the 5th anniversary of Obamacare. 5th anniversary. And during this time, that has had the greatest significant change in how private medicine is delivered in this country. More doctors have changed in the last 5 years, have become working for either large clinics or hospitals than ever in the history of American medicine. And the reason for it is that it is becoming more and more difficult for doctors to run their own business and then practice really good medicine. We're really fortunate. We have fabulous physicians. We have fabulous practitioners. We have wonderful staff. We've got to figure out how to pay for it. And so as we do that, we've got to look for ways to find the best way to maximize the dollars. When we think about who pays for our health services, keep in mind that 1 in 4 Oregonians is in a CCO, is covered by Medicaid. 1 in 4. And that's the same case here in Lake County. 1 in 4. And what the legislature is planning to do, you heard Chuck talk a little bit about it, all of the teachers, their health insurance will be included in the CCO. All of the state employees, so all the people that work at the prison and other state functions, will be included in the CCO. So if we don't contract with the CCO, we have a problem for our community. And that's really important for Lake County. So what does a rural health clinic do? Rural health clinics were established in 1977 after Vietnam to help bring rural health care and bring practitioners to the rural health care. Because people were leaving in droves. And they continue to leave in droves. Right now, 2% of all physicians that finish their residency, you know, keep in mind, a doctor goes to school for 4 years of college, 4 years of medical school, and 3 years of residency. So all the physicians that are coming out, there's 120 that graduate this year, 2% are going to go to a town that is smaller than 25,000 people. 3% will choose to work on their own.
Did your new doctor finish his residency? Is he board certified?
No, he's not.
Is he going to be?
You know, but that's not the question.
No, that's my point. That's what I'm asking.
I understand that. I understand that. But I think that the important thing is 97% of all the physicians that are coming to any community don't want to work in their own clinic. They want to work in a hospital or a large medical group. That's not true? Well, that's what the studies show. And so a rural health clinic is an opportunity for the hospital to bring in doctors. Our clinics have not been able to add new doctors. It's expensive to bring new doctors. And the doctors that do want to come want to work in a clinic that is owned by a hospital or a large medical group. And that's
Are
why
you sure about that? They want to work for the hospital?
maybe we can answer the questions afterward.
We came to have them answered here.
If
Now.
you just wait a minute, please, let's finish. We're almost done, and then we'll have written questions. Thank you.
So the whole point of a rural health clinic is to allow us to recruit new physicians. If one of the other clinics wants to recruit physicians, we would love it. Unfortunately, it's very expensive and they haven't wanted to do that. If you look at Eastern Oregon, actually if you look at all of Oregon, there are rural health clinics that are owned by hospitals in all of the communities that have rural.
Why are they sending our money to California then?
Why are we sending our money?
Yeah.
If we could address that in the question and answer section, that would be great. So that's the reason why we would open a rural health clinic.
Thank you, Charlie. I put Don Liedtke off till last because everybody knows Don pretty well and likes to beat on him a little. And it's tax time, so put him to work here.
No new jokes. Actually, wow, I haven't seen this many people since Lake County Fair at the rewrite. And you're all standing, that's good. But I really want to thank you all for coming tonight because this really shows the spirit and the caring that this community has for what goes on. And it's important that we all get together and have an open and free discussion, and that the questions that come in will be answered as they come in, and this is why we have Lori here to help us out with that. But we're all here for the concern. Okay, I'll hold it up here higher. I only have 47 pages here, but I think I'm going to cut it down because they've already covered a lot of the territory that's here. But we are in a time of change. It's undeniable. And the change isn't always easy, and it isn't always fun, and it isn't always fair. The change has been a constant challenge to this community and a constant challenge to this board as to how to address these changes as they come up. But we must change, and that causes the friction and some problems that we do have. Change came to us when this community voted overwhelmingly to put in a new facility. What did we expect to happen? Change is coming through the increased workload that this new facility, the MRI, and all the wonderful things that we put in that improve our lives. We don't have to travel hundreds of miles now to go have an infusion or to go get an MRI. We can stay at home, it's comfortable, and it's less expensive for us. It's a benefit to every one of us to have this facility that we do have. The change is coming through federal law, and the change is coming because we have such darn good doctors that people come here to get their treatment and their care. Our doctors are the vital link in this community. But it is a hospital community. There is also housekeeping. Think about those folks, or the nursing staff, and all of the people that work in the hospital to make this community work. If we don't adapt to the changes that are coming through, we're going to see the same poor results that have happened in other communities around our area. You know what we're talking about when we say, when we stand still, we're going to go down. So we need to be looking at the changes, and we need to make these things. The changes that we've done so far have been positive. The new facility is undeniably positive for what we've got here. One thing that I think that we haven't done is recognize what these changes are doing to our doctors. We have the same number of doctors that we've had for years, but the workload has increased dramatically. And we need to focus a little bit more on providing our doctors with more support. They're having a tough time getting people in on their own, and this is where the hospital comes in and can help. And we can help with providing better wages, more doctors, better coverage in the ER, and that translates to better services for everybody in the community. And this is what this board is focused on, is providing better services for this community all across the board. So we are committed, so I had a big speech. I got off track. We'll just leave that alone. But we are committed to supporting these doctors and this community and helping them provide the support, the things that they do out of love and duty to this county, we are trying to help them do. So I'm going to cut it short. Again, thank you very much for everybody being here and showing the support for this community and the board and the hospital, because I know you're all here in the best spirits of this community. And we welcome your constructive questions. Chuck?
Thank you. We all got here and got a new hospital by working together, so we want to keep that up if we can. There's lots of things that we can do together to make things better as we go. I'm going to turn this over to Lori Crocker. She does a wonderful job of moderating, as you're all aware, and she will take it from here.
What the board has asked me to do is to tell you that they're going to take a break, about a 15-minute break, 15 to 20 minutes, however long it takes. There's refreshments back there. They would like very much for you to write questions on a card. The cards are now in the lobby, and they would like these questions to be tasteful. They would like for them to be informative and positive, and perhaps if you have a solution to the problem, any idea of a solution, if you could state it on the card. Also, if you would like to have a board member contact you, please sign the card and give your phone number. They would be happy to do that. The parameters have to be that the confidentiality questions cannot be answered, such as salaries, personnel matters, or ongoing negotiations. And I think that's fairly well understood. So in the spirit of trying to hold the community together in a medical process that I hope that people have a better understanding with people coming, please ask questions, because that's how we learn, that's how we get answers, and that's how the board knows what you are thinking. Again, if you have solutions, please offer those on the card, and we will read them. And they are committed to stay here and to answer your questions. So at this time, we will adjourn for about 15 minutes. Yes? If you feel comfortable signing the cards, surely. You do not have to. You do not have to. But the questions that these people are here to answer, and that the doctor has come, and that Kevin has come to answer, I would think that there would be a lot of those, because there's difference in private insurance and then the state insurance. And I think sometimes that is where confusion happens. And if we can clarify any of that tonight, that would certainly, I think that would make everybody go home just with a little more ease and everything. So in the spirit of agreeing to disagree without being disagreeable, please ask your questions. That's what we're here for. Okay, we're all patients. We love our doctors, and we want to keep them here. So let's have cookies and water, or whatever it is, coffee back there. Thank the Senior Center for providing all this, and please write your questions and turn them in to the three ladies in the lobby. And that's Susan Kahn and Debbie Simitaki and Judy Stewart. So let's adjourn for about 15 minutes, all right? Thank you.
Just expanded basically. You watch Animal Planet, Cooking Channel.
We're just about ready. But one of the questions that came in, I have some information on right now, and this was a very helpful one. It says, is there a website for additional research and questions? It would help everyone get answers on their own. So if you're interested in that, I have that website if you'd like to take it down. And that's www.lakehealthdistrict.org. And they'll be happy to respond to that. So the question was, it would be helpful and for everyone to get answers on their own. Is there a website for additional research and questions? And so it's www.lakehealthdistrict.org. Okay, and we'll start in just a minute. There's just a multitude of questions. Some are duplicated, and we're trying to put them together real fast.
Could you just start? About 9 months. Originally Washington. School. I moved from Metropolitan Utah. That's where I went to school.
Wow, big differences.
It's easier trying to go through you guys.
Okay, right. Sorry.
Oh, okay.
They're hard to find here.
I think I lose my brain.
Okay, shall we begin? We have a multitude of questions for the board, and they might want to say who would like to answer this. And so we'll begin with that. So Chuck, would you like to start? And I might say that I'm going to ask them to save all the questions. They have assured me that they will. These will be put in a packet, and then they can peruse them, again tomorrow and everything. Everything will go back to the hospital. Okay. Is our hospital publicly owned? It is operated by a public board. So if it is public, why are salaries a secret and supported by taxes? So how much is Charlie Coit's yearly salary?
Exactly what she asked you not to ask. It's not near enough. I'd let Jim Lynch, as our attorney, let Jim Lynch as our attorney answer whether those things can be disclosed.
There's also statutory confidentiality. That's why they cannot be disclosed.
I'm sorry to be flipped on that, but if you knew what other salaries were, you would realize I wasn't out of line.
Okay, this is sort of a three-pronged question that we have. Are we losing Dr. Bradbury? And has the whole situation created a no confidence feeling among the medical clinic, the doctors, because of Charlie? Are we going to be able to keep Dr. Clark?
Yeah, that's several parts. Dr. Bradbury's contract is up in, I believe, end of June, is that correct? And he's been working half-time here, half-time in Napa, California. He's told us, he sent us a letter that he is going to not come back for another contract. I think that has to do with his wife preferring Napa to Lakeview. But we're in the process of trying to find another surgeon. So this time, maybe 2 part-time surgeons. Has the whole situation created a no confidence feeling among the medical clinic doctors? There's been discussion, and we have, I think, resolved a good deal of that issue at this point. And I think we're going forward and we're going to resolve the entire issue. But we've got to make our doctors have a better environment than they're in right now. They are stressed to no end, and we knew that 6 or 7 years ago, and we haven't really changed the situation. If you've got to work every 5th night, all night, and then go to work in the clinic the next day, sometimes that all-nighter is a tough one. We've got to change that, so we will. Are we going to be able to keep Dr. Clark? We would love to keep Dr. Clark. This is up to Dr. Clark, it's not up to us. We're going to change the environment, and we hope that that's something that he will appreciate. I think time is what he needs to think about that. That's about as far as I'm going to say.
The next question, if we are still going to have the same standard of care, why are we hiring doctors who can't get board certified?
I'm going to let Charlie explain this. Our doctor we hired is a good doctor, but I'll let Charlie.
Dr. Lance Lee has been in the residency program for 3 years at the Cascades East program at Klamath Falls. They elected to leave the residency. So he's had 3 years of residency training, and he's here for as long as we have a need for him, and he wants to be here.
All right. Yes.
I want to add one thing to that. Dr. Lee also has worked here before in Dr. Clark's, not Dr. Clark, Dr. Graham's clinic. So we know him, and the doctors agree that he would be a benefit to us.
Folks, we have worked with Dr. Lance Lee for 4 months in our clinic. He is an excellent physician. All of the physicians have Dr. Gallagher, Dr. Hussey, Dr. Graham, and myself. We all recommended to the board that he be hired by Lake Health District. You also must realize when you get out of residency, no physician is board certified when they first get out.
Can you drive a car without a license?
He is a medical doctor.
Not licensed.
He is licensed. He is licensed.
Just study on?
why 3 months ago, Dr. Clark was offered his services, he offered his services to take OB call at the hospital for all the doctors and was told no. And two something doctors were hired for a larger amount of dollars versus our own doctor. Why was that?
I don't want to get too much into personalities, but this was because besides offering to do the work, he also demanded a change in the salary. And I don't think that we can do business that way. We have to agree on things in a proper manner.
When we already have such a hard time getting doctors, why aren't we working to keep the ones we have?
That's what we've been doing. We've been working very hard to keep the ones that we have. The only doctor that has any risk of not coming back in my mind is Dr. Clark, and I certainly hope we've offered to bring him back anytime that we can get along on ideas. He's having a hard time right now, and we need to give him a little slack.
Don't you try to paint him as crazy.
I didn't say that, did I?
Well, I know you guys.
No, I said he's having a hard time.
You know, he's a very competent person and a reasonable guy.
He's a wonderful
And he
doctor.
wouldn't be upset with anything if there wasn't something wrong.
The person says, this is to the board, or sorry, I suffer from chronic illnesses that require constant medical supervision by my primary care physician, who happens to be Dr. Clark. If he leaves, what is the board's plan to have that same level of care available?
I don't know whether I should answer this or Charlie, but we have other doctors that are just as capable in the community. And we are in the process of trying to recruit some more.
And I don't know if you or Charlie would like to answer this. If the doctors work for the hospital, how will they be reimbursed? Will they be subject to inspections by Medicare and Medicaid, or will the present system of accountability be sustained?
I don't know the present accountability, but they'd be reimbursed in a manner that they earn at least as much as they're currently earning. And probably in a similar manner. So much for working in the clinic, so much for working in the ER. That's the way we pay them now. But we're going to restructure some of those amounts. But certainly they wouldn't earn any less than they make right now. But we do hope that we can give them more time off, give them health insurance, and some things like that.
Okay. They're subject to the same audits on either side.
Doctor's certification and also Medicare, Medicaid, any of them can come in and take a look at our records of their records.
Okay, I don't know if you all heard that, but anybody can come in and take a look at all of their records.
Not anybody.
No, but Medicare and Medicaid. Yeah. Well, not anymore. I certainly don't want you looking into my records. Dr. Byman did that once. and he really helped me. So, why did we have to hire Gordon to do part of Charlie's job? And why can't Charlie work with the doctors in a professional manner?
We hired Gordon to defuse a situation which was just totally out of hand, of name calling back and forth, and nobody could hear the other side. So it was time to get somebody that everybody knew, everybody trusted, and is working very well.
Okay, thank you very much. Let's see. If you like your doctor, can you keep your doctor?
Shall I give the Obama answer? When we get done, everyone everybody in the community will have access, in my mind, to every doctor in the community.
You have your own? Your own doctor? Your own doctor's got all the records, knows your body, any new doctor, any other doctor does.
Take the words I said. That's all I can tell you is everybody will have access to the doctors that are working in the community. That's all I can tell you.
I don't know if Dr. Hoffman or Kevin have any insight into that, but how does that work with 1/4 of the community being under the Oregon Health Plan? Do you have anything additional? I think that's one of the concerns. I don't want to be reading into that, but I know sometimes people have and there's some of the cards that indicate that they're afraid they won't have access because their insurance won't allow them to have access to their doctors. I hope I'm stating that the way that it was intended on the card.
So, one of the requirements that we have is that our members, will, which are people that are on Medicaid, and that's the only group I can speak for tonight, are required to receive their services from what's called a person-centered primary care home. So that means exactly what I heard from the back, having their entire care taken care of or coordinated by a doctor who knows them very, very well. And that doctor is responsible for, we have to spread our members out so we have adequate coverage and adequate access, and that we do allow patient choice in doctors. So I don't know how the configuration here in Lake County will work out for the other 75% of the people in the county, but I can tell you we will be looking very, very closely to see and help with all clinics in this county to achieve that person-centered primary care home status. And that's one of the functions that Dr. Hoffman has been working for us for the last, what, 2 years, Chuck? And I can tell you, when we started as a CCO, only 3% of the clinics in Eastern Oregon had that status. And now over 70% of our members are seen in that status of clinic. So we actually want to strengthen the bond between doctor and patient, provide more care extenders to the person-centered primary care clinics, and have a person's whole health better coordinated.
While you're here, there's a group of questions. Well, there's a group of them. What is the connection between the EOCC and the seeming displeasure between the current doctors and the EOCC? Basically, if it's so great, why aren't the doctors on board?
So I think what you're talking about is why wasn't a contract struck between Dr. Clark and the Eastern Oregon Coordinated Care Organization. While I was not the one negotiating the deal, Sean Jessup from Moda Health was involved in the negotiations. I can tell you that every year I sign a contract with the state and federal government that manages Medicaid that's 353 pages long at this point in time. And that contract is laden with lots of things that you end up holding your nose and saying, are we going to accept the money or are we not going to accept the money? And that's the way the current game works. So there are things embedded in that contract, such as access to records and access to premises, that are embedded in state and federal requirements. That's part of the contract we signed. That's part of the contract that we ask all of our providers to sign. That was a point that we actually went to the state and asked for a waiver on, and they were not able to give, and certainly all the contracts are reviewed by the Center for Medicaid and Medicare Services, and they do not give on that particular issue. The reason is their primary concern is fraud, waste, and abuse of Medicaid and Medicare monies. And in order to prevent that, and that's a growing area that they're spending money to prevent, access to records and premises is paramount. Records to see if the billing was done correctly, premises to see that people have people with disabilities and other folks have access to services.
Okay, while you're still here, why are the teachers and state employees, why do they have to be switched to the EOCC insurance?
That, while that was a goal of Governor Kisshopper, that is not a done deal. It'll be discussed over the next several years. I don't know that what the legislature is going to do around that issue now that Governor Kisshopper is not the governor anymore. But I can tell you that the Summit product that, or the Synergy product that was put on the marketplace by MODA this last year includes the bulk of the providers that are in the Eastern Oregon Coordinated Care Organization. So I don't know, if I were a public employee, I don't know that I would be concerned about whether the CCO was going to be my insurance company or not. I know right now you have a choice between two plans, the MODA plan or a Providence statewide plan, and I suspect there will continue to be choice on that matter.
Just for clarification, can you explain to the audience what MODA, what the acronym means?
It's a Latin word for the way.
Well, I know that because I'm a Latin scholar, but the fact of the matter is, this is where confusion becomes very paramount, because is MODA the same as EOCC? And the answer is, I think, is no, but people need to be told that by people who are in charge of these programs.
So I'll run down the list of owners of the Eastern Oregon Coordinated Care Organization. ODS Health, which used to be ODS, Oregon Dental Service, changed their name for their healthcare product to MODA. Was I right in what it means? Damn. Not even high school. I was in the top 25% of my class. So the reality is MODA and Gobi founded the CCO. Each of us owning 50% of the shares in the CCO. We decided to offer ownership to broader groups than just the two of us to get more community engagement and community involvement. 4 major hospitals in the Eastern Oregon region, St. Anthony's, Good Shepherd, the St. Alphonsus Group, and Grand Ronde Hospital in LeGrand, each bought 10% ownership in the company. And IPA in Pendleton owns 1%, and the federally qualified health center in Hermiston owns 1%. So we, Gobi, have an equal voice in the CCO as MODA does. It's an interesting combination of I think it's unique in the United States, where you have a commercial insurance company that's aligned with a group of hospitals and a behavioral health managed care company, an IPA, and a federally qualified health center. I know it's certainly unique in Oregon.
Thank you so much. It appears that you are adding another government agency. Is that what this is? EOCC?
Well, actually, as I said earlier, there were 3 agencies managing the health plan for the citizens of Lake County prior to this happening. There was Gobi with the mental health benefit. There was Pacific Care or Pacific Source or fee-for-service for the majority of the people in Lake County for the physical health benefit, and then Advantage Dental or other dental care organizations for the dental care. So it's collapsed 3 into 1, and I would say the jury is still out as to what the efficiency will be as we work our way through this prior patch.
And we are glad to have an up-to-date hospital, but why should the hospital be reimbursed at a greater rate than the doctors?
That's a subtlety or a nuance of the way that Oregon requires us to pay for services. type A and type B hospitals, or critical access hospitals with under 25 beds, which is what we have here in Lake County, are required to be paid with a formula called cost-based reimbursement. And by them being able to bill at that way, they and also the rural health clinic can access funds, what are called wraparound funds, that are able to draw down other dollars as well to match what we pay. So it's not unusual at all. It's a fact that was here prior to the CCO, the cost-based reimbursement. And I do want you to know that both private clinics and public clinics can be a rural health clinic. It's not limited to just the hospital that could be a rural health clinic.
Okay, there are 3 or 4 more. Okay, and then probably some more. All right.
I knew Chuck wanted to answer that.
From the presentation, it appears that we are in the hands of the government, and we better acknowledge it, so we can get services we're paid for. What will it take to change this?
So, I don't want to go on a rant here, but I will tell you that if you're at 138% or less of the federal poverty level of your adjusted gross income, which is the number that appears on the bottom of your Form 1040, you're eligible for Medicaid. That is it. That is a huge change over what we had in December 31st of 2013.
Medicaid or Medicare?
Medicaid. And Medicare is still disabled or over 65. The change is, I can tell you, having worked on a ranch and owning my own small business, Medicaid is now going to be, I think, an option for a lot of people that would have never thought of that as an option before. Like it or not, it's a federally funded benefit. 100% of what they're calling the expansion population is paid for by the federal government for the first 5 years. We're at year 3 of 5. Then it'll ratchet down. But people on Medicaid, the bottom that it ratchets down to is 60% federal money, 40% local money. And the reality is, our population in this county on the Oregon Health Plan has grown from 943 people on December 31st of 2013 to 1,664 people today. And that's a tremendous change. Now, many of those people were being seen by your hospital and your clinics. Some of them were on a payment schedule. Some of them were trying to, were getting access through charity care or through funds held by the hospital. But the reality is that's where the growth in insurance has been over the last year. And we need to adjust our system to think about how we take care of people to keep them well with the money we get, rather than just having them show up in the ER when they're in need of medical attention. So the government is a partner in this thing, like it or not. How we get out of it, I guess, is if we form some sort of a co-op and self-insure. And those same values are going to be paramount if we were to pull that off, and maybe we could pull that off. But those same values are going to have to be there, of keeping people well rather than paying for sick care, much of which doesn't even exist in Eastern Oregon, let alone Lake County. You get to the higher end specialty care and you get to tertiary care.
Oh yes. You know, this is wonderful to have people come that want to be informed, and so we appreciate everybody being here. I know, and people will just bear with us, and we'll get through these questions. If our primary care physicians leave, can we obtain medical care from a physician in a different city?
Yes.
I'd like to ask a caveat onto that. How about if you're a veteran and cannot and the doctors here are not certified, or whatever it is for the veteran care, can they go outside and get another doctor? Do you know, are you familiar with that?
I don't know.
Okay, all right. And I will try and read this. The handwriting is a little difficult, but it says, why in America healthcare is for profit if the insurance companies, hospitals, doctors, and CEOs who run all these organizations are at the expense of the taxpayers?
There are for-profit CCOs, there are not-for-profit CCOs. And most recently, there is a national healthcare company called Centene, which is traded on the stock exchange, which bought out a CCO in Lane County called Trillium Care. So we have a whole different dynamic at play today than we've had in the past. Gobi is a private not-for-profit. ODS was set up as a private not-for-profit. And the hospitals that are owners of the CCO, I believe all of them are private not-for-profits. So our commitment is to whatever money comes from the government to provide health care to our members in these counties is going to be spent within these counties to the best of our ability.
And perhaps you've already answered this, but in good faith, I'd like to reiterate it. What are the negatives of the EOCC? And it has not been signed by the clinic, and you're aware of why. Obviously, there are drawbacks. What are they?
So, on one hand, you could say, well, you know, Lake County only has 1,600 of 50,000 members, so why can't we just look the other way? The metrics that there's a holdback of 3% of the CCO's money, and if we don't achieve 17 metrics, they ratchet down how much of that we get back of our own money. Last year, we only got 80% of that money back because we missed too many metrics. Embedded in those metrics is a requirement that 100% of our members are seen by person-centered primary care homes. And the first threshold of a person-centered primary care home is we have a contract with that doctor's office or with that clinic. So if we can't get past go, then we're never going to get to the ultimate goal of having everybody enrolled in person-centered primary care homes. And I just have to say one more thing. You know, the Latin and the faiths, that all brought it up. I spent a lot of time as an altar boy, and I'd really like to have somebody critique my Latin back then.
Well, I had a wonderful education, and I was very gifted in language, I guess, and I had the opportunity to do 4 years of Latin in high school and 4 in college. And so, as an altar boy, I'm sure you learned some Latin. Okay, all right, thank you so much. We really appreciate you being here. I'm going to intersperse now with some of the board members and then with Charlie. Let's, Chuck, do you want to take some more of these for the board? Okay, all right. It sounds as if things have boiled to a crisis in part due to very poor communication. A paternalistic condensation that's approaching the boundaries of bullying by maybe the CEO. Is anything being done to educate him on interpersonal communication skills?
I really can't answer that question. That's not a reasonable question.
Okay, and we thank you for your answers. My taxes on my property are paid for the expansion, and now it is being taken over by a government program. Where is the money coming from to buy equipment and buy out the clinics?
Since I got on the board, or Bob and I got on the board in 2007, our finances have been very solid, and we've got good reserves, and they've been getting better these last years. We're very healthy. And compared to other hospitals our size, we're actually doing better than most of them. We get money in the hospital, except for certain areas. We get what's called cost-based reimbursement. To understand cost-based reimbursement, basically we get paid for everything it costs us to operate, plus 1%. But Medicare doesn't allow certain things like home health, long-term care, what's the other one? OB. So those things are paid in a different manner. But you citizens also pay a tax base, which is just over $1 million now, if I recall. It's been going up a little bit. And the nice thing about that tax base is the pipeline showed up and they're ended up paying a big chunk of it. So we're very healthy. We want to stay that way. This rural health clinic that we're opening essentially is cost-based also. So we're in solid ground as long as we do our work.
I would point out that the hospital has gross receipts of over $20 million a year. To give you an idea of where your property taxes are, $1 million. Those property taxes actually support, our losing services that we provide to this community, like long-term care, health and hospice. Those things cost the community a tremendous amount of money, and that's a good portion of where your tax dollars are going. It's going into support for this community. So yes, we get a lot of reimbursement from Medicare and Medicaid and the insurance companies and private pay. That's where the money comes from. It helps us pay for our hospital and our things that we've got here. We also get money coming from California that comes up. That helps. There's a couple $1 million a year that comes in. That helps us pay for the staff, for the lab, for all sorts of things that we've got here. So it's the property tax portion is vital, but it's not a big, large portion out of $20 million.
Yes, Karen.
And I just say that at their last audit, the financial statements, the breakdown for us would be for patient accounts receivable, Medicare 31%, Medicaid 10%, other third-party payers 30%, and self-pay 29%. So that's how it was broken down in 2014.
Thank you.
Why is it okay for the CEO and board to send money to Cedarville instead of using it here?
I think you're referring, did you get anything further on this? Charlie, you can go ahead.
I think one thing that people need to understand is it's very common for hospitals, if you run out of a supply, you borrow from another hospital. It happens frequently. Our hospital neighbor in Cedarville has had some financial trouble. And they came to us and said, could you lend us some pharmaceuticals? We said, if we lend you those, that'll get you through a week or so. How do you get on your right foot? And so we lent them the money. They've already paid half of it back, the terms that they agreed to and the board agreed to. But it was a function of being good neighbors. It was not a gift. It was a loan, and they're paying it back. And I think that's important, that we all work together. This is very difficult to keep. There are hospitals that are closing all over the country. And they're closing because more and more people, number one, are leaving rural communities. Number two, doctors aren't coming to rural communities. Jobs aren't here. We have to work to try and keep them together. Or we become, as Kevin said, a landing strip in an ER. We don't want to have that.
Why aren't we paying off our bills instead of lending?
Okay. Charlie, I think we'll go on, and maybe that question won't be answered as we go along. This has to do with recovering monies that are going to California, and have you answered that? Okay. It's why does the Lake County Hospital need Cedarville, Alturas, and the hospital under one roof? And will we recover the monies that are going to California? We want our hospitals and doctors.
When we look at working with California, when the analysis was done in 2007 to justify building the expansion of the hospital, we looked at how much business is coming from California because we're so close. And at that time, the analysis said, work more with the people in California because they're already coming. It was about 2% at that time. It's now about 10%. That's a lot of people coming from California here. In 2010, we were approached by one of the doctors who had a rural health clinic in Alturas and said, I prefer working with you in Lake County than I do in my community. Would you be willing to purchase our clinic and we will send patients to Lakeview? We did. Over the last 5 years, the hospital has invested about total of about $800,000. It's a lot of money. In exchange, the amount of money that is generated from people that live in California is over $10 million during that same time period. So it's been a good return for the hospital here, as well as for that community in California. And I think it's important that people keep in mind that when California residents come here, they buy gas, they shop at our grocery stores, they store, convenience stores, they see our doctors, they do business with our professionals. That has helped a lot of Lake County. So it isn't just that we're spending money and it's not coming back.
No, what I'm getting at is we're not paying on our loan.
Why are we, if we have a shortage of doctors and doctors are overworked, but then we're bringing patients from California to overwork our doctors here, we kind of made it all on ourselves.
It is, okay, and I think that maybe some of these other questions will, and hopefully they will address that. Is money the most important goal, and can Lakeview support California, or should they? And that's part of I think your effort.
I think it's important to understand that money is not the most important goal. What's most important is that we provide the best quality that we can. But it takes money to do that. And so as we're able to deliver more service, that means that our nurses stay as competent as possible. All of our staff members, the more that they do better jobs at that. So it's important that we keep that going.
Where did the $30,000 go and why? And did you answer that?
I think I answered that. The money went to pay for pharmaceuticals, and they're paying that back.
Could you clarify the difference between the Warner Mountain Medical Clinic and the Lake County Medical Clinic, such as why one has had an easier time of being certified than the other? I think I'm reading that correctly.
Well, first off, Warner Mountain Medical Clinic is Dr. Graham and Lisa Cahill. Lake County Medical Clinic has been, I don't know if Dr. Bob started it, but it has now Dr. Clark, Dr. Gallagher, Dr. Hussey, and Roseanne Fitzgerald, and Chris McAllister. That's the difference between those two. They are for-profit organizations. Yes, they're physician practices.
And who pays the rural health clinic staff?
The rural health clinic staff are employees of the hospital.
Who are they? Distinguish there, two rural health clinics. One is Warner Mountain, the other one is Lakeview.
Thank you. Just want to make sure that that's clear. Dr. Graham, which is Warner Mountain Medical Clinic, and Lisa have a rural health clinic right now. And they have had for, what, 4 years. And so then the other clinic that the hospital has is also a rural health clinic, and that is a nonprofit because we are a district hospital.
What options do we have when seeing a doctor at the walk-in clinic? Are the expectations of credentials and experience being met?
Well, the options of being seen is that if you make an appointment, you can be seen. We try to do walk-in where we can, but we encourage people to make appointments, just like any other doctor's office. Are their credentials the same? Physicians and nurse practitioners and physician assistants have to meet the same credentialing as if they practice at the hospital. So it would be the same.
Okay. This question, what about continued care to the rest of the ones not covered by the Obamacare or the government aid? And our seniors who are still being paid up in the health care, are they caught up in the health care coverage costs? And second, where and who is not the question. The doctor acknowledged must be as knowledgeable to the patients of Lake County as well.
I think the first question is, what about continued care? I'm assuming that that's related to Dr. Clark. I don't know what that, but I would hope that, I mean, all physicians provide continuing care, and if you have a relationship with your doctor, I would hope that would continue. Where and who is the question? The doctor must be. I'm sorry, I don't know how to answer that.
Should the 26% of the OHP patients dictate the care of everyone? In your opinion?
No, I don't think so. I think we want to deliver the best care we can to everyone, no matter who their insurance company is. We don't want to distinguish at all. And I don't think our physicians do. We certainly don't discriminate to anyone at our hospital. We try to provide the best possible care to everyone, and we will not change that.
Okay, we've talked a lot about Medicaid patients. How will the Medicare patients be affected by all of this?
Once again, I would hope that the care of everyone is treated the same way. But that's a relationship between the doctor and the patient.
Okay, recently I had a bad experience at the ER with a doctor that was not one of the primary Lakeview care physicians. I am therefore concerned about OB calls at the hospital. When I go into labor, will my primary physician be called and be my doctor, or will it be an outside contracted doctor?
That's a good question. All of our doctors that are taking OB, that continue to take care of their patients, I presume they will continue to take care of their patients. With Dr. Clark taking a sabbatical, we will be looking for physicians that will be able to provide the same kind of service. So I would hope we would find them very quickly. That's our goal.
What is it going to take to get 2 at least new doctors into this district? Our doctors cannot work in these conditions effectively for much longer, right? This has to happen soon, or all this will crumble that has been put together, even though the facility is great. Thank you.
I think we're repeating ourselves, but it's important to understand that physicians that want to come here, or that we're trying to encourage, they would want to come and work for a set fee and have limitations of what they would do, and so we're looking to find those physicians. That's how we add physicians. We hired a physician recruiter several months ago and have been looking for physicians and have several possibilities, and hope to have them here as quickly as we can. You know, it isn't just, as those of you that are employers, when you have to look for somebody, you don't just take the first one you get. You have to find the best one you can. And that's what we're doing.
And a few of these questions, they're parts of other people's questions, but I'll read the whole question, the whole card. How does the fact that the newly recruited doctor is not board certified impact the quality of healthcare in our community? Are we receiving subpar doctors? Does the hospital meet federal and state requirements when employing non-board certified doctors?
Once again, we're repeating ourselves. All the physicians that we would recruit have their medical licenses, and we look for the best competent physicians we can.
Is the administration just telling the doctors and thus the community what is good for them? Do the doctors have a say in what will help them best, or is that being decided for them?
The doctors have a big say, and this is why we hired Gordon, so that we could work one-on-one with the doctors and spend some time here. His first thing that he did was build an inventory of things that the doctors wanted to do in their business. Some of the doctors wanted to do less OB, some doctors wanted to do less what we call or ER, and some of the doctors like ER better. So he went down with each doctor and spent a couple hours going through, what do you really want to do with your practice? That was his first step. He's come a long way since then, but we're trying to tailor this to fit what our doctors want, because they're some of the best, and we want to keep them. I do want to make one comment on recruiting. All these doctors that we got, Dr. Bob recruited them, really. And today, these doctors that we have don't have the time to do that. That's one of our issues. So we've got to get out and get at it. The new recruiter that we hired is working especially for us instead of hiring headhunters that we've had to do in the past. And we're getting much better results at this point.
And while you're here, Chuck, was all of this discussed with our doctors before the contract was signed with the hospital clinic? And would we have been able to avoid this mess it had?
If we could have got all the doctors in the same room and they could have all sat down and actually worked with us, I think we could have got more done. They have known for years now that it was our goal to open a rural health clinic. There was no good time to do it in their eyes. I think we all have our faults on both sides of the issue, but we're at a point now that we're going to get past this.
Okay. Recognizing that recent decisions will affect decreased income for our physicians' families, what can the board and administration immediately do to remedy this situation, save taxpayers' money, and keep our physicians here? And perhaps you've answered that, but I think in fairness we need to ask that because the person...
It's certainly our intent that the doctors are not going to make less money.
My family and I are OCCO. When this happened, suddenly waiting for appointments became a much longer wait. This needs to change very soon. Also, is there any work that can be done by those of us with internet access that will help the doctors, hospital, and so forth? Thank you.
Anybody want to answer that? I don't know how the internet's going to help. Maybe Lisa's got an idea.
Actually, the answer is yes.
Yes?
Yes.
Thank you.
I could come up and expand upon it, but the idea of apps and the internet to help people manage their own health care is an emerging issue, particularly with people younger than me. And it's something in rural communities that we really need to use, not only internet access, but telehealth opportunities to bring care here rather than having people go to care. And those are areas that the CCO is definitely exploring and committed to try to bring as much care to the community and have people travel as no more than they have.
Thank you, Kevin. I do know as far as internet goes, we use high-speed internet all the time. If you go down and get an MRI or whatever, it's read by somebody that's not in Lakeview, and we get a report back in hours now. So it's a big factor. I forgot the first part.
Some of these are repetitive but have a little different twist sometimes. St. Charles Hospital in Benton has doctors on staff and also gives hospital privileges to individual doctors in private practice. Why couldn't Lake Medical Center do the same?
I guess one thing, St. Charles, give you an idea of how changes are occurring in Benton. A year ago, St. Charles employed 50 physicians. Last month they employed 210. And it's not because the physicians there were struggling, it was because in order to keep the physicians in and able to provide the kind of service at St. Charles, they felt that was necessary. So that this is not just happening in Lakeview, it's happening all over the country. But more and more physicians are becoming a part of either large clinics or hospitals. And that's just across the country.
Okay. Some of these, and jump in, any of you that want to. We have some more questions that are concerned about what was the issue between our doctors and the managed health organization. I think maybe that has been answered, you feel? We've heard a lot about boards and how they're working for us. How much have the doctors had to say about the decisions? Do you have any other comments?
I want to point out, you're dealing with two different, if you want to call it boards. Our district board operates the hospital. The doctors have their own medical staff, which is essentially a board. And we don't tell the doctors what to do, and they don't tell us what to do. We try to work together because that's what we need to do. But they're two different entities.
Okay. A big concern for this person is to keep our regular doctors and the FNP happy. Okay? Does anybody want to say anything else about how the urgent care facility works? Will it only be outside doctors staffing it until you get regular doctors?
We have one doctor right now.
Right? Mm-hmm. And that's Dr. Lee, correct? Okay, and the final comment on this card, I know people are concerned about having a different doctor every time they go. Was there ever an issue of Charlie being deceitful towards the doctors?
It depends who you ask. We're trying to remedy those concerns, and we're comfortable with Charlie as a board. We're comfortable with Charlie. We think that where we've gotten in the last 6 or 7 years has been tremendous, and we've got a problem we're trying to get worked out.
Okay, and is it true, and this is a forum in which we invited them to come and ask their questions, and so we'll try and answer everything we can. Is it true that Dr. Clark was threatened with losing hospital privileges if he did not become a part of the CCO? Well, I think it's
EOCC. No.
What's going to happen to all the doctor's patients, especially Dr. Clark's? Are the clinic doctors going to take care of all of their patients, or are there any prospects of several new doctors? And that part you've answered, but do you have anything to say for the rest of that card?
I assume that it'll get taken care of in one of the clinics.
This is from a person who knows the answer. It says Dr. Clark is leaving on sabbatical for R&R, or was it, or something found out by the Obamacare rules?
I can't answer for Dr.
Okay. Why did Dr. Clark take a sabbatical? And I think that's been answered. Because of the CEO and the board. Do they remember who owns the hospital equipment and the funds? I think those are comments. What happens if the Affordable Care Act is terminated in a few years?
That's above my pay grade.
All right. Okay. Another part of that question is we know possibly why Dr. Clark took a sabbatical. He's wrote his patients. Since our doctor is leaving, what do we do about prescriptions?
I think it's important for everyone to understand that Dr. Clark has his own medical practice. It's his own business. He has two partners. He and his partners will decide how they're going to manage the care of their patients. That's not a decision made by a hospital, certainly. It's the private practice of medicine. Dr. Bob might say something.
Charlie, if I could bail you out just a minute. There were two names that haven't been mentioned tonight, and that's Roseanne Fitzgerald and Chris Callister. I know them personally. I was involved in their training. They are excellent. I would personally see them and have them see my family at any point in time. And they haven't been mentioned, and they're a tremendous resource. Hank Ortega, you may have remembered way back when. Excellent physician assistant. Those two people are going to take a lot of the burden off. And you can help Dr. Clark by, number one, not making him feel as though he's abandoning us, okay? Because, again, there might be a statement read that I wrote tonight that Lori may or may not read.
I will read it.
But I can assure you that as of 9:30 this morning, Dr. Clark is intent on returning to his practice in Lakeview, Oregon. In 6 months. And that's not even a question. When you see his wife, Judy, uptown at the store, greet her, give her a hug, let him know they're missed. Best thing that we can do to get him back. And he's not replaceable, I'll tell you that. Dr. Clark is a special doctor.
Thank you very much. And this question says, would the doctors in the hospital board be willing to mitigate, bring somebody in to help with this problem and to keep the public involved? And I think you have mentioned that Gordon has come in, Gordon Ansley, and there are several questions about continuing these open meetings so the public will know what's going on. And people would like that. And they also think that our board of directors are basically from the same socioeconomic backgrounds. How can we recruit a diversity of backgrounds and history of new ideas? And new blood brings new ideas. Do any of you have any comments on anything like that?
I will tell you that Bob Swart is not going to rerun, so in July he'll be replaced. And the person that I know has put their name on the ballot is Jane O'Keefe. I don't know if that helps your diversity or not.
And the question of, are you willing to have more public community meetings to keep people involved? And this would solve a lot of rumors and community concerns that I have been hearing.
We're underpaid, but and overworked as well. If it's any time of tax season, I think we're all willing to work. So we'll try to do what you wish. Yeah, all our board meetings, thank you, Don. Very good. We meet once a month, regular board meetings, first Thursday of the month, and it's at the hospital in the big conference room. And you're more than welcome to come to that meeting. And I usually try to visit with the audience at the end of our business and to see what's on their mind. So that's a good place to come. I don't have room, we don't have room enough for this many people. But if we need to have another big meeting, we can sure do it. We're here to have a good health system.
There are three questions that we had about, is Mr. Twait failing to meet his contractual obligations as if the former CEO was brought in to negotiate with the doctors, and having a working relationship with the doctors is an important component of his contract. Is that not true?
What's that old saying? You lead by telling people what you want to hear. We asked Gordon, and bless his wife, because she really didn't want him to do this, to come and help us out. And Gordon loves the community and loves his doctors and his hospital. And there was a personal conflict back and forth that we wanted to defuse. And I think we've done that. Gordon's not going to work for a long period of time. But we are going to make arrangements to try to have a better situation so we don't have a problem in the future.
Okay, and there are a few questions still remaining, and some of them are of a sensitive nature. But it says, why has there been no accountability or consideration on behalf of Charlie Twait or the hospital board of the fact that several physicians do not want to work with Charlie anymore, and Gordon had to be brought in? Why is this not being addressed? It is being addressed. Okay. How much of our problem is really personality conflict? And sometimes isn't it easier to get a different administrator than recruit a skilled doctor?
Charlie doesn't have an easy job. When the doctors communicate to him, one doctor says, don't hire any more help. Don't open a healthcare clinic. And other doctors say, we need more help. It's difficult. And this is what got us here. We weren't communicating well. This is why we stepped in as a board to get this straightened out. But it's not all Charlie's fault. He's been given misdirection. I think we're going to get past that.
This is a three-pronged question. How many doctors asked for Mr. Twait's resignation? What were the stated reasons given for asking? And what were the board's stated reasons for denying the request?
I think these discussions were in executive session, so I'm not allowed to share them with you.
Thank you. Now, Chuck, here's one for you and Don Liedtke. Why did you promote your own well for the geothermal project? Why did you promote your own well for the geothermal project?
This has nothing to do with doctors.
Just say I want to get filthy rich.
Don and I had an opportunity in the middle of when the city was talking about geothermal with the hospital and the schools. We had the opportunity to buy the well at Hammersley Canyon, and we had not a lot of time to work on it. We had been advised by Daryl Anderson, or I had anyway, that that was by far the best well in the community, and it is. It has the most heat in it, the most gallons per minute, and so on. So we stuck our neck out and we bought it. We offered it to the city several times, several ways, at essentially our cost, if you want to look at it that way. And of course, the city chose not to use it. Well, what we got was heat for the school, which is green, heat for the hospital, which is green, but nothing to spare for the rest of the community. Our well, if they'd spent the same dollars, would have had enough heat to heat most of the buildings in Lakeview. So I'll just leave it at that. We were smart enough to just drop the issue because they weren't interested, but we were trying to be good citizens.
Okay, thank you very much. We're coming to an end now, and let's see, conflicts of interest. Judy, I think this one is for you. Judy Graham is Dr. Graham's mother. Why is she participating in this without this being stated?
Okay, you can, but I would like to address that because I do think that that has been a concern in this community. 6 years ago, when one of our board members, when one of the hospital board members decided they could not complete their term, I was asked to sit on the board. The board appointed me, and at that time I was just leaving the school district, and I have always had a real huge interest in healthcare. I've had a real huge interest in this community. My entire life has been from small communities, and I have felt that healthcare is critical, and I thought that would be really fun. It would be interesting. I bring some things to this board. I've had a number of years in boardsmanship, a lot of different facets of boardmanship, and I have that knowledge. I knew at the time that the doctors did not work for the hospital board. We are not responsible for what they do. We are not responsible for their bylaws, if you will, and their medical profession. So I felt there was no conflict of interest. There has not been, in the 6 years that I've been on the board, a conflict of interest. I have been very unbiased. I have been very honest. Had there ever been a need, I would have walked away. To this date, there has not been a need for that. This is touchy, this is difficult for me, because I want to preserve every doctor in our community. I absolutely do not want to see any of them leave. I want the best health care that we can have in this community. And I do want to add, just a little side note here, that when Chuck just moments ago addressed physician recruitment, we have every intention of having our doctors involved in physician recruitment. It's not going to be done by the CEO, by the board of directors. It will be done with all of our medical community involved in that. I hope that answers your question. I will not sit on this board. I will not be involved in any sort of a decision-making process that is detrimental or anything like that with a doctor. Any doctor, doesn't matter who they are. Chuck?
I will tell you, Judy is a wonderful board member, very helpful, and she's been very concerned about conflict of interest. She almost didn't rerun. It weighed heavily on her, but she's not had an issue with it. We have a process, because almost any of us in here can end up in a conflict of interest in a small town. Example being myself. I wrote the software that the hospital used for billing for years, 20 years, and I ran for the board, and I still was in the company that sold that software for about another year. I discussed it with Gordon at the time and said, is this going to work? And he said, there is a process. You can declare a conflict of interest if there's an issue comes up regarding that conflict. You declare a conflict of interest. And I might have done that on the hot well too. I don't remember. I think I did actually.
Thank you. And you all have been very patient. We are coming to an end. But Charlie, I have 3 questions for you. And then I have 2 more after that, and then a statement by Dr. Bommingen. And then I have something that Lisa would like to say also, Lisa Cahill. In the past, I asked you why you wouldn't open the hospital's pharmacy to the public, thinking it would help pay the hospital off quicker. You stated you didn't want to step on Jeff Howard's toes. That's crazy. Help me understand why this is any different than you opening the rural health clinic and stepping on our doctor's toes.
Jeff has a great business. We're happy to work with Jeff as much as we can. We try to continue doing that. The ability of the hospital, our software, to have electronic prescriptions go to the clinic, or to the pharmacy. We've worked at trying to get that to happen. We've tried to work as much as we can to work together. And that is a continuing, ongoing thing. Where we had trouble, why we needed to open a rural health clinic, is we need to be able to recruit additional physicians. And we don't have a place to put them in. We also need to be able to contract with the CCO. So it's a different situation, but that's the reason.
Okay, and I have 2 more questions. How is a considerable monetary benefit that is being passed from a wife's CFO to her husband's CEO not considered a gross conflict of interest by Charlie Twait and the hospital board?
The CEO at Cedarville, or Surprise Valley Hospital in Cedarville, is Rich Cornwell, who's sitting right over here. His wife is our chief financial officer. There isn't any link in terms of why when we lent the money to Surprise Valley Hospital, pardon me? That didn't come into play. It was about hospital to hospital. So that was not an issue, never has been an issue.
And is CHIP the local advisory committee?
You may have seen John Adams that was here. He is the manager of the CHIP process, which is the Community Health Improvement Plan. That is also the Community Advisory Council that is involved with the CCO to try and provide input and advice. They have been meeting monthly. We have several members here that are members of that committee. It's always an open meeting and everyone is welcome.
Thank you very much. There's a question here that I want any one of you to answer please. And it says, when did free speech get suppressed? Would anybody like to answer that? I think what I will do with this card, because I can't quite read all of it, I want you to consider it in the packet, and then if the person signed it, perhaps you can get with them. Okay? I have 3 more cards, and then a statement from Dr. Bommingen and then Lisa. This card says, I appreciate our doctors and our hospital staff. Having worked with persons with disabilities, it is hard and economically and physically hard to get out of town. I hope Charlie and the board know they are appreciated. We are truly blessed to have the beautiful medical facilities and outstanding medical professionals in our community. It appears the board is now very aware of the overload on our doctors and are taking action to remedy the problem. Let's learn from the board, let's learn from this bump in the road and move forward in a positive light. As addressed previously, the key to success here is going to be a long communication process in positive relations with each other. And this is signed and says, God bless this community for their concern and support, and all of this will be reread by the board members. Dr. Bomagen's statement says, 20 years ago, I took a sabbatical and to return 9 months later. Very similar issues, but look what this community has done. We are here because we are a community and we care. I offer to help in whatever capacity I am asked, be it for the doctors, the mid-level departments at the hospital, the administration. And it's signed Dr. Bob. And I would like to remind people again that there is a website for additional research and questions, and it would be help if everybody got on the same page it says here. And again, that website is www.lakehealthdistrict.org. And again, in closing, just about, I want to thank everybody for coming, because we are all patients of the doctors, of the healthcare system. I think I own 2 wings of the hospital now. In the last 3 years, as you know, it was Mark. And we have been treated very, very well. And we are very appreciative. We're appreciative of our insurance companies and everything like that. At this time, I would like for Lisa to come forward. She would like to say something. And again, if you have additional comments, please contact Chuck Kelly, who is the chairman of the board, or any one of these board members. They are open to you. They will sit down with you individually. Okay, Lisa.
I just have 2 things that I would like to clarify, and one is physician recruitment. When I first started practicing as a mid-level here in 2004, I have been involved since that time in trying to get physician recruitment. I've sat at Dr. Bomagen's kitchen table recruiting physicians to come here. It is an arduous, painful process, and all of the physicians have been involved with this. So this isn't the board bringing physicians in for us to look at. It's basically us reaching out through headhunters, through different ways, through the OHSU residency program to get physicians to come here. It is very true that residents sign for a job with hospitals now. They are basically told by the residency not to sign to a private practice. So Dr. Graham and myself trying to recruit a physician is almost impossible. It is even impossible for the hospitals to try to get that physician to come here. So please realize we work very hard to try to get physicians in here. We take residents, the clinic takes residents, we take residents, so we can work with these folks, so we can show them Lakeview, so we can build a report to say that, hey, we want them or we don't want them. But I will tell you folks, it is probably going to be Lake District Hospital is who's going to hire those physicians, because that's where they want to go. I also want to say something about the rural health clinic. 20% of my private practice comes from California. I don't ask if you want to be one of my patients where you live. A lot of my patients that I truly enjoy come from California, and I'm not going to stop that practice. However, if you are at California Medi-Cal, I cannot be paid. Lakeview Medical Clinic cannot be paid. If you choose to come see us, you have to pay out of pocket. That will not be true for Lakeview Hospital-run rural health clinic. And so I may probably lose some of those patients because I do not want my patients to have to pay me out of pocket. But you have to understand, we have more cows in this community than we have people. And we are trying to run a hospital financially solvent with less people than cows. And where the veterinarians come and help us when we really need it, and we thank them for it, it isn't a day-by-day practice. So there is certainly issues with that border, but they are good people. We want to help serve them also, and they have helped our community also. So please understand that where they help us, we help them. It is a joint position, and we'd like to be able to serve them on a financially easier basis for them too.
Chuck would like to say something. Chuck Kelly.
Yeah, I want to thank you for coming tonight and taking your time. I certainly have learned a lot here tonight. I'm sure you have too. And I also wish I could speak as well as Lisa. But we do appreciate it very much, and we can do this if you need to do it again. And we probably should have done it sooner. But we're going to get through this.
So on behalf of the board and our guests from the insurance companies and our lawyer, Jim Lynch, we really thank all of you for coming tonight and participating. We have to go into the community and continue to learn. Thank you for coming, and good evening.
Our board is taking a 15-minute recess, and then we have to go back to work.